Good evening to all the viewers who are watching live and will be watching as the recorded version. I, myself, Medical Mukherjee, just hereby welcome you all in short. And without wasting any more time, let's just start our today's CME with the 30 seconds countdown time.
Good evening, everybody. Good evening, sir.
Ah, good evening, very good evening.
And we are crawling towards half century of online CME. Today is 43rd edition of our online CME live. And we have very eminent speakers tonight. But to introduce tonight's speakers, moderator, I'll request take permission from our president, Dr. Narayan Kalyani, sir,
Sure,
to
sure.
bring upon our inaugurator tonight, Dr. Manjeet Singh, our backstage editor, Orko. Please bring Dr. Manjeet Singh on screen. Dr.
Good evening, sir.
Good evening, very good evening.
I think I'm loud and audible to all of you.
Yes, ma'am,
Hello.
you are audible and very visible.
Okay. So we'll start today's CME. It's my special honor to inaugurate 43rd Continued Medical Education. I would like to thank Dr. Bidyut Mukherjee, Dr. D.N. Kalyani sir, Dr. Chandrasekhar Pore, Dr. Pralay Sharma, Dr. Ompriya Mishra, Dr. Kishore Naskar for giving me chance to offer inaugural speech in the virtual platform. It is my special honor as I have longest duration of stay as a student at National Institute of Homeopathy while completing my BHMS and MD in homeopathy. I must thank all the respected members of our alumni for their interest in development of knowledge in the profession and to feel proud that we are from premier role model Apex Institute of the country. While inaugurating today's CME, I wish this CME will be very informative and will unveil certain dimension in the field of homeopathy. We have among us today's speaker, Dr. Rajiv Sarkar. He is 7th batch BHMS and have completed PhD in epidemiology from CMC Fellow. He is assistant professor at Indian Institute of Public Health. Today, he will speak on the topic COVID-19 pandemic and unpacking the evidence. We also have today's speaker, Dr. Tirthankar Banerjee, 21st batch BHMS. He is university topper. He has completed his MD from Government of West Bengal and presently he is Assistant Director of Banerjee Healthcare. Today, he will speak on the topic A Treatise of Clinical Haematology for Practitioner. As a moderator, we have with us today Professor Dr. Samir Manna sir. He is 7th batch BHMS and he has also completed MD from NIH and working as professor at Midnapur Homeopathic Medical College, Government of West Bengal. I request our speaker to speak today and often to solve the difficulties in the practice and research methodology and to guide efforts of alumni association. I wish today's webinar will encourage all of us present in the virtual platform to the further dedicate ourselves in the providing best to our education policy, and patient care. So thank you so much, and over to today's moderator, Professor Dr. Samir Manna sir. Over to you, sir.
Thank you, Manjeet Singh,
Thank
inaugurator
you.
of this session, 43rd online CME, and that is organized by NIH Alumni Association. One correction that I am not a professor of Midnapur Homeopathic Medical College. Previously, I worked there, but at present, I am professor in Mahesh Bhattacharya Homeopathic Medical College. Okay, so today we have two eminent speaker. So warm welcome, hello, and warm welcome to both of them. One of them is my batchmate, Dr. Rajiv Sarkar. He will speak about uh, the COVID-19 and unpacking the evidence. Uh, and from his discussion, we hope that we may gain a better understanding about the present scenario of the viral, uh, that means the surveillance of genomic surveillance or the genomic information about the present status of the virus. And also we may get some knowledge about the impact of the virus, of the disease that has had in India and abroad. And also we may gain some knowledge about the common misconceptions that is related to COVID vaccination and other things. So without further delay, uh, I like to request Dr. Rajiv to present his presentation.
Thank you, Shomir, for the wonderful introduction. And I'd really like to thank the organizers from the NIH Alumni Association for inviting me to this. So I think this is the second time I am speaking in this particular show. Can you all see me? I can't see myself.
Sir, we can see you, sir.
Okay, perfect. Thank you. What I will do is I'll quickly share my screen and I'll start my presentation without much ado. Just give me 1 minute. And please let me know when you can see my screen. And can you see the presentation?
Yes, sir. For privacy purpose, I just keep it on backstage. Just
Mhm.
open up the presentation, and I
I
will
have
just let the screen on screen.
I have opened up the presentation. Can you see that now?
Then, sir, you have mistaken something, sir, with the system. Let me check. Oh, sir, yes, sir, you did a slight mistake. Please do the resharing part once again.
Reshare, share screen.
Yes, just stop sharing. Stop. First of all, just click on stop sharing. Then again, click on share. Share screen.
Mhm.
Then, then you will get a miniature version of your screen. Just click on that,
Mhm.
and after clicking that, or it will be showing over at the top that entire screen. And right at below, there will be a small means miniature format of your screen. Just click on that and click on share.
Okay. Now,
Now, do turn on the presentation.
yes.
So yes, there is some problem. There is some problem, sir.
Okay, just give me a minute.
Sir,
Let
I
me see.
think. Sir.
Now let me know if you can see my presentation.
Yes, sir. Just click on the slideshow, sir.
Yeah. Is it okay now?
Can't see the slideshow part.
Cannot see the slide. Now?
Now, yes, sir. Now
Okay.
your cursor
I'll
is
just
moving on the screen.
Yeah, I think I will not do a full screen share. I will go with this, in the interest of time, because it could be that it might sometime take a while for me to do a full slide share. So I
Okay,
think
sir.
we'll go ahead. This is okay, right?
Okay, sir. Yes, sir.
Okay, so thank you. Just a very brief background. I am Rajiv. I was a seventh batch BHMS student at NIH, following which I did my master's and PhD in epidemiology from CMC Vellore. I am currently in Shillong. I'm teaching at the Indian Institute of Public Health Shillong as an associate professor. So what I'm going to talk today about is COVID, and what is the current evidence base for the different things in COVID. Over the last 2 years, this pandemic has completely changed the way we live, and completely changed our lives, and probably we have to live with this new normal for some time to come. So if we talk about COVID, the world woke up to a new virus which was reported from the Wuhan in China in December 2019. There was a few cases of clusters of outbreak, mostly linked to a seafood market, and so on and so forth. And things unfolded very, very fast, very rapidly after that. And in January 2020, WHO declared this pandemic as a public health emergency. And finally, in 11th of March, WHO declared COVID-19 to be a global pandemic. And since that day in March 2020 till today, as I was mentioning a few minutes back, that a lot of things have happened in our lives. We have had to go through lockdowns where we have had months of restricting ourselves to our homes, only venturing out for emergency activities. We have had to undergo school closures. Those of us who have kids, we know how difficult it has been for the parents, uh, mentoring their child through an online system of education for a few hours. We have had to undergo travel restrictions. We're not allowed to travel freely. If something happens in another city, in another state, then we had to, and we still do have to look at what is the protocol allowing us, and so on and so forth. So things have really, really changed dramatically over the last 2 years. Currently, if we look at it, and this is a few days back, which I downloaded from the World Health Organization website, we have a little more than 43 crores of confirmed cases of COVID globally, and around 59 lakh deaths. When we talk about India, there's about 4 crores of confirmed cases and about 5 lakh deaths. And we know that this is a gross underestimation, and I'm going to come to it later. So these are just confirmed cases and deaths. And even with this underestimation, the numbers are kind of mind boggling. A lot of us have had to undergo the pain of losing a near and dear one to this pandemic. We didn't even have an opportunity to say goodbye to them because of the restrictions and things like that. So this has really, really touched all our lives. And although we said about 4 crores cases and so on and so forth, as I was mentioning, that without even the confirmed cases, and I'm really sorry, the slide is very, it is a difficult to visualize. I thought it would be a full screen and people could at least see it. This is a very busy slide, but believe me when I say this, that when we looked at the percentage of asymptomatic infections, what we are now finding, what the current evidence suggests, that among those who have tested positive, almost half of the people are asymptomatic. So that is a large number. And if we reflect back to 2 years back during the initial stages of the pandemic, the initial reports that was coming in, even the WHO technical advisory, if someone of you would want to read those advisories in March 2020 and so on and so forth, you would find that the initial evidence suggested only 1 to 5% asymptomatic infections, which is not the case now. The current evidence is there's a huge number of asymptomatic infection, and that is also coming out of sero surveys, where we find that the case to infection ratio is about 11 is to 1 is to 11, which means for every one confirmed case globally, we have about 11 people who have had the exposure but was undiagnosed. And that shows the extent of this pandemic, the extent of the impact of this pandemic globally. And this case to infection ratio discrepancy is not only true of a country like India, where it has been shown to be about 56. For every confirmed case, there is around 56 or 60 people who have been infected but not diagnosed. Of course, this is probably going to change with the Omicron, because this is kind of the results are from the pre-Omicron surveys. But it is also true of other places like the Americas, USA, for example. If you look at the top data here, you can see that the overall case to infection ratio in terms of the missed infections in the US is also about 7. Similarly, in the European region, and so on and so forth. So there has been undercounting throughout the world, and these are what the sero surveys are showing us now in terms of the infection. So the whatever we are seeing from the WHO dashboard, the WHO website in terms of confirmed cases is only a fraction of what the true infection is. In fact, there was a modeling study done to looking at the contribution of asymptomatic and pre-symptomatic transmission. And the modeling study, based on the assumptions and based on the data available, found that at least 50% of new infections, 50% of transmissions are from individuals who do not have symptoms. In other words, they may be completely asymptomatic, or they may not have symptoms at that point in time, maybe later on may go on to develop symptoms, but they were largely people without symptoms. And that is very important from the public health disease control perspective, right? Because all our measures, if we look at it in terms of asking people to self-isolate and so on and so forth, could only happen if the person has the disease symptom. If the person does not have the symptom of disease, then it becomes really difficult to control. Or at least, it becomes challenging to a certain extent. And that is exactly what we are seeing in terms of this outbreak. Despite stringent lockdowns, despite people staying on closures of the entire country over a large period of time, we were not able to see the amount of we never reached a zero COVID. We did see a reduction in the number of cases. Probably if there was no lockdown, then there would have been a much more faster spread and so on and so forth. But we did not come to a zero level. And this has happened globally. And this is one of the reasons is because of this contribution of asymptomatically infected people to transmit. And this is important because when we are talking about a public health measure, when we are talking about what we need to do, because at this point in time, we are talking about opening up of the globe. We already have reports that UK has lifted all restrictions and other countries are slowly following suit. We need to be cognizant of the fact that we have not reached a zero COVID situation. We may never reach the zero COVID situation for that matter. And hence, there would still be transmissions happening. There will still be infections happening. And we need to keep our guards up. We need to keep our personal protective measures intact for at least some more time to see how the situation unfolds. There has been a lot of interest about different variants. The original variant, the original SARS-CoV that came out of Wuhan has mutated in the last 2 years, has mutated into different variants. For example, in May 2020, a new variant called B1.1.7 or alpha was detected from UK, which was said to spread more than what the Wuhan variant spread. A few months later, a beta variant came out of South Africa and a gamma from Brazil. Finally, in the October 2020, from India reported what is called as the Delta variant, which caused the second wave of the pandemic in the early 2021 in India, which is B6.1.7. And more recently, earlier in January, end of December, early January, we had the transmission from the Omicron variant. And already we are hearing reports that even within the Omicron, there is another subfraction which may cause another outbreak. We don't know. So this has been mutating over the over the last 2 years and has become more adaptive to the human scenario. For example, Omicron, as we all know, caused a lot of diseases, but did not cause a lot of deaths. And that is probably one of the reasons why the governments throughout the world has decided that they would rather open up the economies, given that the number of deaths have now come down. But what it also means is that going forward, there would be chances of other variants that could emerge. Other variants that could emerge because of vaccine inequities, because of uh, because of the fact that there are a large number of people who are still unvaccinated, and that could result in this particular virus staying there for a long period of time, mutating. It could also result from human animal interactions. And I'll come later that there are now experimental evidence to show that there are certain animals which would also get infected with SARS-CoV. And there could be the disease transmission in that population, which could then come back and reinfect the humans. There's already an evidence for that, and I'll talk about it a bit later. So this is what is called as a phylogenetic tree, which shows how each of the variants are related to each other. For example, if you look at my cursor on the right, and this is what is the Delta variant, which caused the second wave of the pandemic. These gray ones are the original COVID, the ones that emerged from Wuhan, and the Omicron here can be seen as red. And what we also see is in this phylogenetic tree is that, for example, the Delta and Omicrons are poles apart. In other words, they are not very close together, right? And of course, there could be other variants that could emerge over time, which would then be added to this, which gives us a lot of information about the evolution of the virus over time. And this is the same phylogenetic tree on a time scale. And if we can look at it in terms of the evolution, we can see that we started with the original Wuhan variant, then we had Alpha, then there was a lot of Delta, and now there is this Omicron subvariant, the B1 and the B2 subvariant that is now catching up. So we can see in terms of time how they emerged and how they evolved over time to adapt to the human hosts. And not only that, as I was mentioning, that there is now evidence from experimental studies as well as from looking at the different animal species that there are animal reservoirs of infection. And some of the animal reservoirs are actually domesticated animals such as cats and dogs. So there is always a chance that there could be these reservoirs which would continue to transmit amongst themselves and then at some point may reinfect humans. As we notice that the SARS from the original has mutated quite a lot to come to the Omicron variant. It is also possible that within these animal species they could further mutate, and then a mutated variant could come back. And why it is important in terms of public health? Because it calls for surveillance not only at the human level, but also at the level of the veterinary, also at the level of the animals, to understand how this virus is evolving in the animal species. Are they becoming more adaptive or less adaptive? There has already been a strong evidence of a transmission from human to minks, and then from the mink population back to the human population. So there has been a cross-species transmission, which is from human moving on to the mink and then coming back to the human population. It was already recorded. And it is quite possible that we could have transmission from cats, dogs, and other species as well. So that is something that we need to keep in mind. We need to keep a watch for as we progress through this particular pandemic. Of course, what happened before COVID and post-COVID, our lives has completely changed. We are all very well aware of words like contact tracing, quarantine, isolation, social distancing has become the norm. We talk about hand hygiene. In fact, we did a study in Meghalaya during during in 2020, asking about people's hand washing practices at the height of the epidemic. And what we found is that a lot of people who said that they did not wash hands or washed hand less frequently before the pandemic was washing hands more frequently after the pandemic. So these things have changed unknowingly, even to us. We never used to carry a hand sanitizer with us. I never knew what a hand sanitizer was before this COVID-19 pandemic. And now all of us, or most of us, have hand sanitizers in our bags when we travel. Face masks have become a norm, which was, never the case. And of course, over the last 2 years, we have lived on lockdowns and isolations. And these measures, although they are now being lifted in a phased manner, in some places much more faster, in some places a bit slower, if there is a new variant which is more dangerous and things like that, which is more virulent and things like that, there could be again reinstated, and we are living in constant fear of that. So what is the evidence that these measures work? Or was this a fancy, was this a completely fruitless effort, futile effort, and we just went through the pain for nothing? Well, there are some studies which has looked at the impact of these measures on the transmission. This was a modeling study which was done to look at the effect of lockdown policies on COVID. And there's a whole bunch of different policies or interventions that they looked in. For example, travel controls, international travel controls. We had the normal international travel that we know of is now again slowly coming back, but for the large part of the last 2 years was non-existent. There were air bubbles which were operating between countries, and airlines was using those air bubble arrangements for travel. Right? Similarly, closure of public transportation. Still, our public transportation is not back to normal. Our schools are closed. Our workplaces are opening up, but many places it's working with half capacity or very limited capacity. Our public gatherings are cancelled. There are restrictions on the number of people who can gather, for example, for marriages or even for funerals. And then, of course, there has been stay-at-home requirements and even restrictions for internal movement. Moving from one state to the other state within a country has been troublesome. And this modeling study looked at the impact of each of those on transmission. How did the cases come down or not come down based on those policies and what? And of course, this is modeling, so this is not, probably there are some uncertainties around the reality. But what it largely found is that things like school closure, workplace closure, cancellation of public event or restrictions on gatherings, anything where people would come together had an impact in reducing the transmission. Whereas things like international travel closure or things like restrictions on the internal movement did not have that much of an impact. And that is understandable because of the way this disease is transmitted, right? It is transmitted from one person to the other. And hence, any kind of a measure that reduces contact, that reduces gathering, that reduces people coming together would have an impact. And that is what it kind of shows. Similarly, in terms of the personal protective measures, we are now well aware of the fact that we need to hand wash, we need to wear a mask, and we need to maintain physical distancing. And this is a meta-analysis which looked at evidence from different studies and looked at a pooled evidence to see whether these kind of public health measures, this kind of personal protective measures were effective and what was the magnitude of effectiveness. And what they found was that, yes, these measures was effective, hand washing, mask wearing, and physical distancing. But of the three measures, the strongest impact in reducing transmission, in protecting an individual, was for mask wearing. And again, this ties down with our current understanding of COVID, which is mostly a airborne disease, a disease which is the virus which is carried by the air through large or small respiratory droplets. And even there is no evidence that it could be also because of through aerosols, which was not what was thought. And this is interesting because, again, when we started early on in the pandemic, actually WHO came out with an advisory saying that there is little evidence to say that wearing a mask could protect someone from getting the disease. From that little evidence to say that wearing a mask could protect someone from getting the disease, hence WHO does not recommend mask wearing at that point. We had taken a 360-degree turnaround. And what we have found now, what is being discovered, or what is being, what research is showing, is that it could be the single most important preventive measure from getting someone infected. In fact, there are studies which have looked at the type of mask and the degree of protection it confers. And these studies have shown that compared to a cloth mask or a three-ply surgical mask, a N95 or a respirator mask confers a larger degree of protection. So the type of mask that we wear actually is also important in the level of protection. In fact, there are studies, I didn't present it here, but there is studies which have shown, these are experimental studies which have shown that if one person wear a mask versus two people wearing a mask, what is the level of protection? If someone who is exposed wearing a mask versus only an infected wearing a mask, what is the level of protection? These studies have happened. And it has actually shown that if two people wear a mask and both of them are wearing a double mask or a surgical mask and things like that, it would confer more protection than one person wearing a mask, and so on and so forth. And this is understandable because, again, of the airborne mode of transmission of the disease. In fact, still for a long time and still now, what is recommended is 2 meter or 6 feet distance in terms of social distancing. And that recommendation came from very earlier studies looking at a particles movement. I think it was in 1930s or something, which used it, and that has been used by WHO, CDC, and other agencies. But the COVID pandemic actually brought out the, the folly of that kind of an assumption in terms of airborne transmission for 2 meters. In fact, people working on aerosols, physicists who got interested in COVID, who came and did experiments to show that that is not the case. And this was kind of a review or a kind of commentary published in British Medical Journal, which actually gathered the evidences from different studies to say that this 2 meter physical distancing may not be enough. And that is why, if we go back and look at the evidence in terms of social distancing or physical distancing, the evidence is not as strong as it is in for mask wearing. So this pandemic has also resulted in those increases in knowledge in terms of public health. Some of the public health measures that has been propagated for centuries. When we studied public health, we all knew that if it's a large droplet, it doesn't go beyond 2 meters or 6 feet. And the initial assumption again was that COVID is transmitted largely through large droplets and not small droplets. But now there is evidence, there is research, and there was research, but now there is a gathering of evidence, and there is an increasing consensus to say that the 2 meter rule may not be enough, the 6 feet distance rule may not be enough in protecting us from getting infected. Yes, a 6 feet distance rule with a mask wearing may give us better protection. Of course, the talk on COVID is incomplete without talking about vaccines. And we have seen an unprecedented number of vaccines come in for COVID. In fact, there are still in India, for example, if you have to come to Meghalaya, you can only enter without an RT-PCR report if you have been fully vaccinated. If not, you would need a negative RT-PCR report to enter. We are still having that policy. And this is true for a lot of some other states in India too. So if we talk about COVID-19 vaccines, we can divide them largely into four categories. We can something which is called as a viral vector vaccine, which uses a vector, a virus particle which is attenuated, a part of the virus particle, and that is then injected into the body of the human. They are non-replicating. So you have a certain number of virus particles injected. They do not replicate inside the body, but they would then trigger an immune response. The body would recognize it as a foreign protein. They would trigger an immune response, and that memory would remain. So when we are exposed to the COVID, the virus itself, the body can then repel that infection. Then, of course, there are mRNA vaccines. Sorry, before I go to the mRNA vaccine, an example of the viral vector vaccine is Oxford AstraZeneca vaccine, the Covishield, that is being largely used in India. Then there is this mRNA vaccine, and there's been a lot of talk about the mRNA vaccines, the Pfizer and biotech vaccine, for example, and the Moderna vaccines, which are largely being used in the Western countries, which uses a synthetic version of the messenger RNA. Then there is a whole virus vaccine, which is what is the concept behind the Covaxin, which uses the inactivated virus, and then you vaccinate using that inactivated virus. And then there are other vaccines such as the protein subunit vaccine, which uses the fragments of the spike protein and so on and so forth. So largely these are divided into these four types of vaccines. And if we look at the requirements, I mean, as I was mentioning, the mRNA vaccines are usually the common ones are the Pfizer and BioNTech and the Moderna ones, which is used mostly in the Western countries, and they have been shown to they require very stringent transportation and very stringent, cold chain maintenance. They have to be stored at -70, -80 degrees Celsius, and so on and so forth. Whereas the viral vector vaccines is the Oxford AstraZeneca vaccine, which is what is largely being used in India. And as you can see from this table, that other than the mRNA vaccines, the other vaccines, the viral vector vaccine, the whole virus, the inactivated virus, of course, has been used in immunization programs globally. Even the protein subunit vaccine has been used earlier. The mRNA vaccine is something which is a new technology that was used for COVID. And of course, this particular pandemic, as with a lot of other things, have also revolutionized the timelines of vaccine development. When I was studying my master's in epidemiology, we were told that a vaccine development takes about 10 years, because you start with animal studies, then you go to the preclinical studies. You have to first find out what what the target protein is, and so on and so forth. So you do the preclinical studies, then you do animal studies, then you go to phase 1 clinical study, then phase 2, then phase 3, which is a larger clinical trial, and finally a phase 4 post marketing. By the phase 3, after phase 3, if you have promising results, you would be allowed to license the vaccine. So it usually takes a long time, because these are usually stage gated. You do phase 1, then you would look at the phase 1 data, then you will do phase 2, then you will look at the phase 2 data, and so on and so forth. Whereas when it came to COVID, the vaccines were developed in record times. For example, the Pfizer BioNTech vaccine was developed within an 8-month period. And this has caused a lot of questions, a lot of confusions among people in terms of the quality of the research that was done for the development of the vaccines. People have asked this question, and rightly so, that were the adequate, rigorous procedures of a clinical research followed to develop these vaccines, or were they circumvented? Right? So, what happened that these vaccines became available within such a short time span? There was quite a few things which happened. The first thing is that it is important to know that even though we are talking about COVID as a new disease, coronaviruses has been researched, because there has been 2 other coronavirus epidemics and or pandemics that has happened. The 2004 SARS coronavirus pandemic, if we remember correctly, those of us who were still there, I remember because I came freshly out of NIH at that point in time, which has a 50% kind of a genomic overlap with the coronavirus 2, and of course the MERS-CoV-2, which the Middle East respiratory syndrome, which has caused localized outbreaks in some parts of the world. And people have been working on these. So there has been a prior knowledge working on the genome sequencing, what are the spike proteins and all that based on that. And that knowledge was used by the vaccine developers to kind of develop these vaccines for the COVID. Of course, there was also a huge amount of commitment from the governments to buy the vaccine should one be available. And what that essentially did was that because of the money that was available, the money that was poured into vaccine research and development, that some of that, I was mentioning about the stage gating of trials, right? Phase 1 and then phase 2 and phase 3 and so forth. Some of the processes was done concurrently. For example, you have a phase 1, by the time an interim result of phase 1 is available, you could move on to phase 2 and so on and so forth. And also, some of the manufacturing developmental processes could start. Because, even if I have a trial result which shows that the vaccine candidate is promising, to set up the manufacturing, the systems, to put everything in place would take a while before it would be available in the market. Whereas in this case, the companies, because of the guarantees from the countries or the governments that they're going to buy these vaccines, should it be available, and the money that would pour in, governments put in money even before the vaccine was licensed, saying that yes, once it is licensed, I'll buy so many doses. The companies were able to make arrangements to start the manufacturing process also simultaneously. And of course, the regulatory agencies, who are the ones who would license a vaccine, gave some leeway in allowing for rolling submissions. I have some data available. I will put it in front of the regulatory agency. They will keep reviewing the data on a rolling basis, which is what doesn't happen conventionally. Conventionally, we collect every information, you put it together, you make it into a dossier, and you finally submit the dossier. This led to a huge decrease in the time span. And that is something which is going to be very important going forward for newer emerging diseases in terms of vaccines and other product development, because of the fact that this has set a new norm for things to be fast-tracked if needed, without compromising on the quality. Now, as I mentioned, that there are different types of vaccine, different manufacturers that has produced the vaccine. So each of these vaccine also has different efficacies. In other words, each of this vaccine confers different levels of protection. For example, the Pfizer BioNTech vaccine would confer 95% protection in the clinical trials, whereas the Sinovac vaccine could confer only 50% protection. And this is something we need to keep in mind, because it is not the same vaccine that is used globally, but different vaccines by different manufacturers are given globally. The one that we use, the Oxford AstraZeneca vaccine, which is what is marketed in India by the Serum Institute of India in the name of Covishield, confers around 70% protection. So there are these things that we need to keep in mind when we look at protection, when we look at why some countries are getting more disease, where other countries are getting less disease, why someone who is vaccinated is also getting infected, because vaccination again does not confer 100% protection. And not only this, the protection, the level of protection varies, and this is true for all vaccine, by the strains. We talked about the alpha, beta, gamma, and now we are talking about the Omicron strain and so on and so forth. It varies by the strains of the particular virus. as well as the time from the last dose of vaccination or the till to the time of coming in contact, the duration. And that is why a lot of countries are now talking about a third dose of the vaccine, a booster dose. Because what studies have shown is that the immunity, at least the IgG, the that is the immunity that is given, does not remain. If I look at antibodies, it does not, the levels of antibodies are not uniform throughout. Of course, immunity is a very complex process, and it is not only antibody, but it also has B cells and memory T cells and other things which could help. And there is evidence to show that even though there is less antibodies, the B cells and the memory T cells are still around, so they would still repel. But at least from the serological perspective, from the immunoglobulin perspective, it has shown to decrease over time. So these are some of the other nuances that impacts what we see in terms of infection rates and risks of infection to individuals, because it could be impacted by the type of vaccine that has been given, the duration, the time from the vaccination, the last dose of the vaccination to the time of exposure to the virus, to the time of infection, as well as the variant that has been exposed to. Whether it's a Delta variant, then the immunity will be different as compared to Omicron. And we know that in Omicron, we had a lot of breakthrough infections because the vaccines really did not confer, at least from the asymptomatic infection perspective, the level of infection that was expected or anticipated. Not only this, throwing to the complexity, now what we also know is that even the duration, the gap between two doses can be important. And this was a study done in relation to the Oxford AstraZeneca vaccine, where they found that if the interval between the first and the second dose is less than 6 weeks, the protection against a symptomatic infection is around 55%. Whereas if it is greater than 12 weeks, it goes up from 55% to 81%. And one of the reasons, I mean, there was a lot of confusion when the government of India changed the gap between the two doses of Covishield vaccine from 1 month to 3 months. People said that it is because of the lack of availability and so on and so forth. Yes, that could have been partial reasons, I don't know. But one of the main reasons was this particular study, which actually showed that if you increase the duration, if you increase the gap between two doses, then your protection will go up, the level of protection. Not only that, what studies have also shown that the level of protection against a symptomatic disease, people who have symptom versus an asymptomatic infection, is different. And this table very clearly shows it. If you look at the place where I'm putting my cursor on this table, you can see that although the vaccine has been shown to confer 81% protection against a symptomatic infection, it only confers 22% protection against asymptomatic infection if given 12 weeks apart. It may not confer any protection if given within a gap of 1 month. So that there are different levels of protection by the vaccine in terms of infection, in terms of disease, even in terms of mortality. So when we look at the vaccine data, when we talk about why certain things are happening in the vaccinated population, we need to keep this in mind. There has been a lot of talk about adverse events, and what is important, and I've put the definition of what is called as an adverse event following an immunization for us to understand what exactly it means. Because there's lots of reports about adverse events, and people construe that when we say about a vaccine adverse event following immunization, it is related to the vaccine, which as per the strict definition is not true. An adverse event following immunization is defined as an untoward medical occurrence following immunization which may or may not have a relationship, a causal relationship with the vaccine. So for example, if I take a vaccine, I'm a participant of a vaccine trial, I'm given the vaccine, and I meet with a road traffic accident and I die, the researchers will have to report it as a serious adverse event as per the mandates of the drug controller, DCGI mandates, as per as the mandates of the FDA and the European Medical EMA and all so on and so forth. You have to report it as a adverse event. But is it related? Probably not. Adverse events are also classified as minor, severe, and serious. So it can range from anything. For example, I take a vaccine, I have a pain in my vaccination site. That can be classified as an as adverse event. Although it will be classified as a minor adverse event. I have a fever for 2 days, it will be classified as a minor adverse event. Events such as life-threatening, for example, severe infections or reactions which would require hospitalization and so on and so forth, would be classified as a severe adverse event. Whereas things which would require in death and things like that would be classified as a serious adverse event. When it comes to vaccinations and adverse event, this was a study I think done in Jordan, which actually listed all the frequencies of different adverse event following vaccination. And we can see there's a huge list of adverse events that is reported. These are all self-reported adverse events. So there could be different adverse events resulting from tiredness, injection site pain, headache, to fevers, joint pains, and so on and so forth. And the people in that study, the participants were also asked to self quantify it as mild, moderate, or severe. And around 39% of the adverse events reported in that particular study was quantified as mild. In fact, a pooled meta analysis of different clinical trials, different vaccine trials, taking about close to 75,000 subjects, found that in any within a trial setting, about 36% of the subjects had some sort of an adverse event. The percentage of subjects reporting an adverse event in this particular meta-analysis, what they found was lowest in the inactivated vaccine, and followed by the mRNA vaccine, and then the followed by the viral vector vaccine and then the mRNA vaccine. In other words, the frequency of adverse event reported was highest for the mRNA vaccine, which also ties with the reports that we see from India when during the rollout of Covaxin and Covishield, the government of India did ask for adverse event. There's an adverse event reporting system that was activated, and the initial analysis by ICMR actually also showed that the frequency of adverse event reported in Covaxin was less than that of Covishield. And we know and Covaxin is an inactivated vaccine. So the frequency of adverse event also differs by the type of vaccine administered. And it was also found that it differed by age. For example, people above 55 years had a lower risk of adverse events than people below 55 years. Younger people reported more adverse events during a trial setting. Of course, the way this adverse event reporting happens, it is more of a reporting which requires people to report. And if you have mild symptoms, many people may not report. So there could be an under-reporting outside of a trial setting for an adverse event. And there are now reports, there are studies. I was reading one study, I didn't put it here, which showed that they have followed up a group of people who got the vaccines under as a routine, and the number of adverse event reported was low, and that could be possible because of the fact that they are not really actively followed up as a trial participant would. But in general, the vaccines that is currently available seems to be tolerated, seems to be more or less safe. Yes, there are adverse events. People do report fever, people do report body ache and things like that. But the frequency of severe adverse event, at least in the risk-benefit ratio, is low than the frequency of the adverse events that you would see if you would have gotten the disease. Of course, there's been a lot of talk about neurological complications following vaccination. There have been reports of neurological complications following vaccination. And this was a study which did what is called as a self-controlled case series. In other words, you have a person, you look at what happened before the time of the vaccination, and then you post-vaccination, you divide the time period into different smaller fractions, and you look at what happened during each of these. And what this study found interestingly was that yes, there was a higher report of neurological disorders, hematological events, and other things. Oh, sorry. This is an hematological event, and this has been there has been a similar study on the neurological disorders, and they found that there was an increase in the events. But when you compare it with natural infection, it was still less. So if you look at an unvaccinated person without getting infected, as compared to a vaccinated person, the risk was higher in the vaccinated person than the unvaccinated person. But if you are looking also at someone who has gotten infected with SARS-CoV, the risk was much higher with those with the COVID-19. In other words, the vaccines, the risk of these events, which are serious events like venous thromboembolism or cerebral venous thrombosis, was not more in the vaccinated population than if you would have gotten SARS-CoV infection. Although the risk was a bit more than the unvaccinated person without the infection. So these are some of the evidences that has come out. Of course, there is much more out there. There's a lot of things that is happening. There's a lot of churning that is happening on knowledge. There's a lot of knowledge increase that is happening in different fronts. Looking at it from the perspective of the virus, there is evolutionary aspects of the virus. In fact, today I think there was a two papers which has come out, which is looking at the evolution looking at the SARS-CoV, which is happening in terms of where did it the origin of SARS-CoV, and they are hypothesizing that it is indeed from the Hunan seafood market because of two events, or more than one event. It was multiple events that led to this outbreak and things like that. I haven't read the paper. I just saw the notification coming. So there's a lot of new knowledge that is coming in, and new knowledge that is coming in thick and fast. But in general, in terms of the public health, from the 2 years back where we had almost no clue about what we are doing, our knowledge of SARS-CoV is slowly and slowly increasing. And that is where I'm going to stop, and I'd be happy to take some questions if there is any. Thank you very much for your time.
Thank you, Rajiv, Dr. Rajiv, for your wonderful presentation. From his presentation, we definitely gain lots of knowledge regarding uh, uh, various evolution that takes place in the virus and cellular surveillance data he has given, and also he has pointed out about some animal reservoirs. That is a new some animal reservoirs are there, and also if there is animal reservoir, then there is a chance of again mutation. Okay, so and that from that animal a new strain of the virus that can spill over in the human population, and that may lead to another outbreak or another epidemic or pandemic. Okay, so that is a great concern. And also he has nicely described about the uh, effectiveness of lockdown during pandemic period and various PPs. Okay, so effectiveness PPs and various vaccines that is available. Okay, so and that vaccine regarding vaccine he has uh, told about the effectiveness and efficacy. So regarding this, I want to say that uh, safety is the major concern if regarding vaccine, because vaccine is given to the healthy person for prevention. So safety is the prior concern, and if there is some if the vaccine is not safe, then it may cause a lot of problem. And this vaccine is developed in very short span of time, and yes, that leads some question in people's mind that whether that is properly developed or not. And regarding this, he has also told that vaccine, whenever any vaccine is developed, that vaccines first try, there is a animal trial, then subsequently there is three stages, three phases human trial in increasing number, and in third phase there is a we can say effectiveness of the vaccine is actually assessed, and sorry, efficacy, not effectiveness, efficacy of the vaccine is tested in phase 3, and that efficacy, that we know that some vaccine is 70% efficacy, some vaccine is 90% or 95%. That does not mean that the rest of the percentage remain unprotected or they have the chance of disease. Effectiveness and efficacy means those person receiving the vaccine, they are 100% protected, and 70% means that 70% people uh, are in risk, less chance of developing severe disease. So that prevents 70% people having the severe disease. And regarding effectiveness, that is done in phase 4 trial, and I'm not sure that phase 4 trial has done in India or not. And in that trial only we can get the all data related to this AEFI, and AEFI data is not properly available in India. And other point that maybe we can say that there are the data that uh, that we get during the pandemic. Government, there is a hiding of lots of data. Actually, uh, what we know, the number of cases, actually it is more than that. Okay, so there is a lot of hiding of data and misreporting of data, and government is only reporting the recovery rate, not properly the fatality rate. Okay, so that create a lot of confusion among population. So we can say that the science and medical fraternity um, should be means there should be independent. Okay, so they should act independently. There should not be any political interference or infiltration that may cause distrust among population. Okay, so and from this COVID also we can know that uh, it the social and economic inequalities that is prevailing, and that becomes more prominent. We can say COVID act as a torch, and it throws a bright light on these inequalities, and also it acts as a wedge. It increases the gap uh, between this, means it increases the gap of social and economic inequalities in the uh, community that prevails from previously. Okay, and this kind of pandemic, actually it gives us a time, means it comes once in a 100 years, and that gives us a time to means if we see the healthcare system in India, 60 more than 68% of the population lives in rural India, and uh, the healthcare infrastructure that is available in rural area is only 40% of entire healthcare infrastructure. So for future pandemic uh, preparedness, we have to be give proper emphasis on this point. Otherwise, if again another pandemic occurs, then due to this lack of healthcare facilities in rural India, where the majority of the population lives, they may suffer a lot. So there is time for investment in rural infrastructure development. Okay, so that's all. And thank you again, Rajiv, for your nice presentation. Next, I want to request Dr. Tirthankar Banerjee for presentation of his topic, a treatise on clinical hematology for practitioners. Okay, is there any question left for Rajiv?
Sir, the questions will be taken after
At the
the
end.
second speaker ends.
Okay, okay, okay,
At
okay,
the end, sir.
okay. Okay, Dr. Tirthankar, you may present your presentation.
Sir, can I start now?
Yes, you start your presentation.
Okay. Is my slide visible?
No, the slide is not visible yet.
Orko, is the slide visible now?
No, the slide is not visible yet.
Should I start with the slideshow? Is it visible
So
now?
your screen share is not being opened. You have not
Okay,
screen share.
screen share screen.
Yes, and then the entire screen part.
Then what should I do now, Orko?
The miniature version of your screen, it will be shown over there. Just click on that, and
Okay,
if your
share.
presentation contains any audio, then click
Okay,
on share audio. While after clicking that, then click on share.
okay. Is it is
Yes,
it is
now
it
it's
being
showing.
shared now? Okay, is it being shared
It's
now?
being shared. Yes,
Okay,
yes,
okay,
it's being
okay. Should I
shared.
start now?
Yes, just turn on the slideshow.
Okay. Hello everyone.
Now
So
it's okay.
today, okay. Hello everyone.
Please click on
Today,
the hide button. Please click on the hide
okay,
button. Sorry to disturb you in between.
okay. Is it okay
Just click
now?
on the hide button.
Okay, is it
Yes,
okay
it is
now?
okay. Over to you.
Okay, okay, okay. Thank you. Hello everyone. Myself, Dr. Tirthankar Banerjee. I shall today be going to present a conference seminar on a treatise on hematology for practitioners. So before going into further details on the topic, let us directly jump over to the part where the most important emphasis lies into. So, India being one of the most auriferous sources of hematological disorders among the globe, I humbly dedicate my treatise for doctors to those innumerable patients who seek and sought help from us for their conditions ranging from simple iron deficiency anemia to conditions like essential thrombocytosis. So the aim of this presentation is manifold. As being general practitioners, every physician must understand the basics of hematology. Even though we are not specialists, we are physicians, a community's primary care physician, we must have significant amount of hematology. Because to keep the physicians of varying disciplines informed and cautious about the must not miss diagnosis of most common to comparatively rare hematological disorders which we often get in our clinics, but we often miss. Threatening conditions like disseminated intravascular coagulation, which is now surfacing as a significant disastrous complication of COVID-19. High-grade lymphomas often starts silently and kills smoothly. So, early diagnosis in bedside as well as in our clinics requires is a very, very important tool for important patient care. Common hematological disorders and indications might be missed due to physicians' bias and those stuffs needs to be re-evaluated. Recent days, advancement of hematological investigations, which we can do even in our general laboratories, has opened horizons for easy diagnosis. So, to the primary care physician must be aware of them. Monitoring the prognosis, even when the patient is coming for treatment of other conditions, irrespective of the center of treatment. Understanding the scope and limitations is very, very important. Developing compassion, precise idea of the tools needed and must be done to diagnose. Understanding the local systemic signs early during the sickness and developing compassion and expertise in care of a hematological case. So here is a brief review of disease burden. The hematological disorders of India can be broadly classified into two categories. One is a congenital, another one is acquired. So it's very important to understand in which geographical area our practice is focused into. Like thalassemia and hemoglobinopathies coexists in areas of Punjab. India being a country of malaria epidemic, sickle cell anemia is a common thing, which mostly in population of Gujarat and Maharashtra. So a patient complaining of a splenic infarct, a small spleen in ultrasonogram might require an evaluation for sickle cell anemia, especially when the patient is a resident of Gujarat and Maharashtra. Coagulation disorders are very common, the most common being hemophilia and Lanzmann's thrombocythemia. Among nutritional anemias, iron deficiency anemia and vitamin B12 and folic acid deficiencies are mostly encountered, but less common anemias are not unusual to be diagnosed. Now, let us directly skip into the part where diagnosis of anemia, we get often cases in a routine examination, in a routine blood count, the patient is anemic. So, just we get that, we need to understand a couple of questions. What is the RBC size? What is the shape? What is the likely cause? Reduced hemopoiesis or the RBCs are being produced less? An ongoing loss where the source we need to track and an increased destruction of the RBCs. How can the causes be grouped? How to consider differential diagnosis? What are the associated investigation required to reach up to a diagnosis? What are the non-hematological investigations that we might need help from? And what are the other organs or systems are likely to be involved and required to be evaluated? What are the therapeutic measures we can take? What are the managements we can do? And what is the expected outcome? So let us directly go into the part where the RBC destruction is taking place from a reduction of hemopoiesis or lack of RBC formation. So the lack of iron, we know that it will resulting in formation of IgA. It's a very common stuff we get every day. Lack of globin chain synthesis will definitely lead to thalassemia. Lack of iron mobilization will lead to sideroblastic anemia. Whereas, interestingly, lack of marrow action and improper utilization of existing iron takes place in situations like anemia of chronic disease or anemia of liver disease. So, just only seeing a normocytic normochromic anemia in a routine blood count, a routine complete blood count, requires further investigations to understand the cause of it. So here we have shortly groupified the situations where the normocytic normochromic anemia, along with a couple of few tests or few investigations, give us insight regarding the diagnosis of a hidden systemic disorder, like that of a total iron binding capacity. It's a very interesting and tool to measure to differentiate between iron deficiency anemia and anemia of chronic disease, namely like a patient of chronic renal failure or CKD. In iron deficiency anemia, the iron binding capacity is raised, whereas TIBC is low in anemia of chronic disease. Serum ferritin is a very interesting measurement to understand that in anemia of chronic disease, like that of a CKD patient, the anemia of chronic disease, the serum ferritin raises, whereas in IDA, the serum ferritin is low. The third important thing is very, very important one. We get a lab report of normocytic normochromic anemia, low hemoglobin, but we cannot find out what might be the cause. We are confused between iron deficiency anemia or thalassemia. A very simple minimum cost lab test might help us to reach up to a diagnosis that is the RDW or race cell distribution width measurement. An IDA is present with high RDW, whereas RDW is low with thalassemia. Because before we do a smaller investigations that can point towards the diagnosis, we are less likely to put the patient in burden of expensive examinations, expensive investigations like that of electrophoresis. Now the second important test, which we have often forget to do, that is the FEP level. Even when confusion still exists, where the cause of microcytic hypochromic anemia, we have shared a microcytic hypochromic anemia, a smaller RBCs, smaller chromicity may occur with a varying number of conditions, from sideroblastic anemia to iron deficiency anemia, to thalassemia. All these conditions can show us a blood picture of normocytosis, but the confusion can be cleared with measurement of free erythropoietic protoporphyrin levels. It's also a less expensive investigation that might serve as a tool for establishing the diagnosis of IgA. Protoporphyrin is an intermediate of hemoglobin synthesis pathway. Conditions where the heme synthesis is perturbed or disturbed. The unused accumulation of FEP in blood determines iron deficiency. We know that the normal range is 30 picogram per deciliter. Sorry, 30 microgram per deciliter, milligram per deciliter. Finding out the cause. If we have now confirmed the diagnosis of our mostly encountered clinical scenario, that is iron deficiency anemia, we all know where to look for, like menstruation, a GI bleed, diet, hookworms. And the important point where we must not miss the clue to diagnosis is that when there is a condition of hookworm or any one infestation that is creating a competitive symbiosis with the human system and resulting in iron drain, we can diagnose that even in a complete blood count test. That is, the anemia is low hemoglobin, normocytosis, and this is coupled with eosinophilia, that is a raised eosinophils. Whipple's disease and tropical flu are tough to diagnose, where a small bowel biopsy may be needed, but luckily these are comparatively rare to be found in our clinical practice. Celiac disease is a very common disorder which we get every day in our clinic. An anti-TTG antibody can help the diagnosis of celiac disease, even as we cannot ask every patient to go for a small bowel endoscopy or biopsy and so on and so forth. Any other blood losses. So if there is a normocytosis, and we are suspecting the patient has lost blood, so in that condition, a high reticulocyte count might help us to alleviate the confusion of our diagnosis. Now let us directly go to the part where the anemias, the cells are bigger. That's megaloblastic anemias, and the megaloblasts are certain cells which are found in bone marrow. Dietary and absorptional deficiencies are most common. However, important therapeutic diagnosis of three important causes of megaloblastic anemia must not be missed. We all know that megaloblastic anemia is confirmed clinically and pathologically when there is presence of hypersegmented neutrophils. But there must not be certain clues, certain miss out in diagnosis. That is, when these anemias do not response to treatment with supplementation of B12 and folic acid. And those patients who are on anti-epileptic drugs, we must take help from the history of the patient, that whether the patient is taking any anti-epileptic drugs, especially from phenytoin, DBA, synthetic inhibitors for chemotherapy, and of course methotrexate. There are other conditions which are very rare, comparatively rare to be found in clinical practice. But if we can diagnose them, we can properly refer them to dedicated hematology care. That is orotic aciduria. This is very interesting. A very early childhood, we know that megaloblastic anemia from deficiency disorders or absorptional disorders occurs in comparatively elder age group or adult age group. But what is the diagnosis when it is presented in a small kid? That is orotic aciduria, liver disease and hypothyroidism, and thiamine deficiency. Must not miss point for megaloblastic anemia in clinics. If we get in our report that this patient is suffering from megaloblastic anemia, what are the things we should look for? The most important point of megaloblastic anemia in India is malabsorption, blind lobe syndrome of large bowel. Certain patients with heart failure shows picture of megaloblastic anemia, chiefly due to thiamine deficiency. Hence, patients with congestive cardiac failure must have thiamine in their diets. So, as being the homeopathic physician or the primary care physician or the general practitioner to the community, we must have significant amount of idea of the basic nutritional supplements, dietary supplements, what food can be given to the patient. Similarly, the alcoholics who presents with combined alcohol-induced as well as B12-induced megaloblastic anemia, they also have shown to improve with outside given exogenous thiamine supplementation. So the diagnosis can also be confirmed with measurement of serum B12 and folate and thiamine estimation. Estimation of liver enzymes is very, very important and a must do for all the patients with megaloblastosis or megaloblastic anemia. Urine for orotic aciduria, especially in a pediatric age group, if we find that there is a megaloblastic anemia, and of course, measurement of thyroid hormone profiles. Now, another type of anemia we will directly go into, that is hemolysis. So previously, like conditions of thalassemia, conditions of sideroblastic anemia, conditions of iron deficiency anemia, condition of megaloblastic anemia, why all these anemias are happening? These are all happening because there is a lack of production. Lack of production, it may be due to lack of raw material. It may be due to any causes of lack of production. It may be a marrow suppression from anemia of chronic disease, like in those patients who are on CKD patients. Their marrow is getting suppressed from the toxic metabolites, which the kidney was supposed to be clearing, but not being able to clear now. They get suffer from that. But if all these things are normal, but we are still getting that RBC is getting fragmented, RBC is getting degraded, RBCs are getting lysed. So that is known as hemolysis. Hemolytic anemias contribute to our clinic data hugely accounted other than deficiency anemias. These patients are obviously clinically patient presenting with jaundice and anemia. So the anemia and jaundice complex is very, very important. These patients, how we can differentiate these patients? These patients will be having dark stool, of course, and raised AST, raised lactate dehydrogenase. But most importantly, whereas other causes of unconjugated bilirubinemia, which we often get in our clinics, this hemolytic jaundice from hemolytic anemia or hemolytic jaundice can only be differentiated easily in a bedside with a very small test, namely the measurement of urobilinogen in urine. Because in all other conditions of hemolytic or unconjugated hyperbilirubinemia, all maybe the parameters are showing same, but urinary urobilinogen is increased only in cases of hemolytic anemia. So as we can see here, that most important is increased reticulocytosis, and also these macrocytes and nucleated cells can also be found. So the combination here is very important. The patient is anemic, the patient is hemolytic jaundiced, or there is an unconjugated hyperbilirubinemia. And the most important confirmatory clue to the diagnosis is an increased urinary urobilinogen, which we must measure when we are dealing with a case or suspected case of hemolytic anemia. So after we have understood, we have got to know that what is the condition of hemolytic anemia, we must now seek help to know whether where is the cause lying, who are breaking down the RBCs. So this is here we get help from measurement of haptoglobins. Haptoglobin comes out as an RBC degradation product in hemolytic anemia. So here the raised haptoglobin, the RBC breaking down in plasma, also known as intravascular hemolysis, often being accompanied by deep red brown colored urine, as we can see from the right side of the slide, the picture I have shared. And this is why this is happening, because as the RBCs are getting degraded inside of the plasma, they are breaking down and resulting in hemoglobinuria. So the must not miss causes of intravascular hemolysis are bacterial sepsis. A patient with septicemia is giving this colored urine, this brown red colored urine, showing the sign of hemolysis, and consumed raised haptoglobulins. These are very, very important. And this we must measure. Now, the patient is showing another important thing. The haptoglobins are normal or raised, but there is a hemolytic anemia. What does it mean? It means that the hemolysis or breakdown of the RBCs are taking place somewhere outside of the plasma. That is mostly in the spleen. That is known as an increased splenic sequestration. So the increased splenic destruction of RBCs will invariably lead to splenomegaly. So as we can see from the picture, the sign of hemolytic anemia with normal haptoglobulins is also a must not miss diagnosis, as it indicates RBC breaking outside of plasma in spleen. No other clinical differentiation of intravascular hemolysis to extravascular hemolysis is found, so it's kind of a must examination. Causes: any cases where the RBCs are breaking. It may be a cytomegalovirus infection or a mycoplasma infection, a G6PD deficiency. Patients must be cautioned about use of drugs which causes G6PD inhibition, cancers, and cold and warm antibody disorders of different leukemias and lymphoma. So the next not so done investigation we can take help from is the autoimmune hemolytic anemia and Coombs test. In conjunction with certain disorders, autoimmunity plays an important role for RBC destruction. Non-Hodgkin's lymphoma, chronic lymphoblastic and lymphocytic leukemia, mostly lymphocytic leukemia, SLE, and certain infections like CME, they change our immunity to such an autoimmune response that the RBCs get damaged by our own antibodies. These antibodies can be of two types. One is a warm, another one is a cold antibody. These warm and cold antibodies are said so because of their reaction with an ambient temperature. These warm antibodies are namely IgG class of antibodies, and whereas the cold antibodies are mostly IgM class antibodies. So this patient presents with symptoms of intravascular hemolysis and often precipitate an acute anemic crisis from cold, that is paroxysmal or cold hemoglobinuria, may take place from an intravascular hemolysis occurring due to those cold antibodies destroying our RBCs. Which conditions where we must be very cautious and very suspicious about these events, especially when we are trying to deal with patients who are already suffering from CLL, non-Hodgkin's lymphoma, and conditions like SLE. Hence, it is mandatory for us to go for a routine Coombs test in patients we are treating who are suffering from chronic lymphoid malignancies, non-Hodgkin's lymphoma, and collagen vascular disorders. Must not miss investigation for red cell disorders for differential diagnosis perspective. Here we have given certain tests, certain investigations which we can do in our bedside, which can help us to achieve a diagnosis. That is hematocrit and erythropoietin levels, anemia and polycythemia and its causes. Just for example, we can share that a patient with anemia and low erythropoietin level can lead us to a suspicion or diagnosis of anemia from CKD. Total iron binding capacity, as we have said, red cell distribution width, that is iron deficiency anemia and thalassemia, free erythropoietic protoporphyrins, iron deficiency anemia can be differentiated with only this small test from any other causes of microcytic hypochromic anemia. Measurement of the RBC shape and size in form of MCV, MCH, and MCHC. Haptoglobin in blood is always to be done in conjunction with liver function test, as we have said that to understand the hemolytic anemias. Urine for urobilinogen will again confirm the diagnosis of hemolytic anemia from other causes of increased unconjugated bilirubin in plasma. Leukocyte alkaline phosphatase score, it's a rare investigation, but can be done to differentiate between paroxysmal nocturnal hemoglobinuria with CML. Paroxysmal nocturnal hemoglobinuria and CML, of course, with polycythemia. Next parameters we are going is the hemoglobin electrophoresis, very commonly done from to understand the thalassemia. Reticulocyte count, we know that the raised reticulocytosis always reflects more or less a condition where the bone marrow is overstimulated, where the bone marrow is working faster to produce more RBCs. So the very precursors of RBC come out in the peripheral circulation. That can occur when there is a blood loss or hemolytic anemia, normocytic anemia. We must do the basic radiological investigations in every suspected case, like X-ray of skull in patients to know there is a thalassemia, there is a multiple myeloma, splenomegaly, autosplenectomy of sickle cell anemia. What happens in many hematological conditions, the spleen goes bigger. Just like we have said, the spleen goes bigger in any cases of extravascular hemolysis. But a condition like sickle cell anemia, the spleen becomes smaller because of little splenic infarct, as because the tachycards or the deformed RBCs blocking the small splenic vasculature and causing splenic infarction. Now the next is lactate dehydrogenase, a very important and handy lab test for diagnosis of hemolytic anemias and a lot of hematological malignancies in combination. FDP and fibrin split products. This is actually a product when there is an accentuated fibrinolysis, as in cases of any fibrinolytic disorders, but FDP is mostly used to monitor the prognosis of disseminated intravascular coagulation. And complement levels are also to be done when we are suspecting a case of autoimmune hemolytic anemia in cases of CLL, NHL, or other conditions like CVD, collagen vascular disorder patients. So moving on, not going into the further details with RBC disorders, we directly now move on to the coagulation disorders. Our Metria Medica is so enriched with symptoms of coagulation disorders and thrombotic disorders as well, ranging from relatively benign idiopathic thrombocytopenic purpura to life-threatening disseminated intravascular coagulation requires strong clinical suspicion to detect, to enumerate possible causes, outcomes, scope, limited interventions, and obviously timely referral. In coming part, I will try to go us through the must not be misdiagnosis of various coagulation disorders in brief. So a brief classification of primary coagulation disorders. So it can be classified into two categories, where there is a bleeding tendency, where there is a hypercoagulability tendency. So the bleeding tendencies will result in hemorrhage in different parts, whereas hypercoagulability may lead to thrombotic episodes in various parts. The thrombotic episodes might be like so of deep vein thrombosis. If it occurs in brain, it might lead to a cerebrovascular accident or stroke. If it occurs in lungs, it might occur in a pulmonary thromboembolism. It may occur in kidney. It may cause a renal vein thrombosis. It may so and so. So the bleeding states are like ITP, SLE, hemolytic uremic syndrome, DIC, and thrombotic thrombocytopenic purpura. These are all immune mediated. Glanzmann's thrombasthenia, which we shall be describing shortly. VWF deficiency, that's von Willebrand factor deficiency, hemophilia, aplastic anemia, leucation, radiation, and metastatic bleedings. Hypercoagulable states are comparatively rare events, but even also with this rarity, we can come across them. They are like polycythemia vera. In polycythemia vera, this cannot occur. In AP-ALS syndrome, that is anti-phospholipid antibody syndrome, or there is development of a certain antibody, which is known as lupus anticoagulant, which causes a hypercoagulable state. Diabetes mellitus, dyslipidemia, nephrotic syndrome, HRT, that is hormone replacement therapy. This is a very important point, that HRT with modern day coming up, and the ladies are opting for hormone replacement therapy, and hormone replacement therapy with certain conditions, certain situations lead to hypercoagulability. A patient who has done HRT a couple of months before might come to all of a sudden in our clinic with a swelling in the cuff, with a pain tenderness in the cuff, with a positive woman sign. We must not be delaying from sending the patient to the lab for Doppler studies to rule out deep vein thrombosis, because it might lead to death of the patient from fragmentation and embolization. So we have done a bedside classification based on causes. We find a case of bleeding, spontaneous bleeding, so we can now understand where to approach these cases. The bleeding may occur from vascular damage or qualitative damage of platelets and quantitative damage of platelets. So the vascular damage is actually when the walls of the blood vessels are damaged due to any causes, like from scurvy, that is vitamin C deficiency, Henoch-Schönlein purpura or HSP. This is basically an immune-mediated destruction of the walls. Ehlers-Danlos syndrome, we all know that in Ehlers-Danlos syndrome, there is a destruction of the collagen fibers, a damage to the collagen fibers. It's a congenital condition. Osner-Lindy-Weber syndrome, Waldenstrom microglobulinemia, rickettsial infections and meningococcemia and amyloidosis, which can occur from from a long-standing chronic bronchitis. Patient may develop amyloidosis, might develop bleeding in later part of his or her life. Qualitative damage of platelets can occur with Glanzmann's thrombasthenia and von Willebrand factor diseases. Most importantly, this qualitative damage can take place in those patients who are showing spontaneous bleeding spots in different parts of his or her body, that is superficial bleeding in the form of purpura or petechiae, may develop in patients who are taking aspirin in the form of ecosprin for the heart disorder as in the form of blood thinner. Now the quantitative damage of platelets, that is idiopathic thrombocytopenic purpura. Here there is a consumption of the existing platelets. There is no qualitative damage to the platelets, but platelets are being consumed. DIC, TTP, and transfusion reactions and acute leukemia and TLS, that is tumor lysis syndrome. These things we don't usually expect to get in our clinics, but it's good to know them. Investigational approach to a case of coagulation disorder. Here I have made a list, a shortified list, an oversimplified list to understand that what common deficiencies might lead to what common kind of bleedings. That's the factor 7 deficiency and 9 deficiency hemophilia, factor 2, 7, 9, 10 deficiency, vitamin K deficiency, and thrombin time increases with fibrinogen defect. Prothrombin time raises with liver failure. Activated partial thromboplastin time is a very important, significant predictor to diagnosis of VWF, platelet count, and bleeding and clotting time. So this is a chart where all the common coagulation disorders and their suspected alternation of parameters can be found. Where everything is high and the platelets are being consumed, so the platelet count is low, like high PT, high APTT, high thrombin time, high bleeding time. This group is coupled with a low platelet count because of the platelet are being consumed. That takes place in disseminated intravascular coagulation. How will we diagnose this? We can also diagnose this in combination with measurement of FDP. Where there is only prolongation of activated partial thromboplastin time and bleeding time, with rest of the things are normal, we can come to a conclusion of VWF deficiency. Where there is all are normal, only the APTT rises, we can confirm the diagnosis of hemophilia, and this basic investigation panel can be followed by measurement of suspected deficiency of hemophilic factors. Now only the bleeding time gets increased in cases of vascular lesions like in scurvy. All remains normal and there is a sudden drop of bleeding time, that's the qualitative platelet dysfunction, and a raise prothrombin time is a must be done for liver failure. We must take help from our laboratories to understand what is prothrombin time and when the prothrombin time raises in cases of altered significant amount of liver damage. Clinical clues to diagnosis of coagulation disorders. We must remember that superficial bleeding like petechial spots and purpura are mostly due to platelet defects. Hemarthrosis, that is the bleeding in deeper part of the body, spontaneous bleeding in and around the joints, is a hallmark of hemophilia. Recurrent history of upper respiratory tract infections, palpable purpura in buttocks, arms, etc., and associated with fever, gastrointestinal bleed, especially in children, and signs of nephritis is actually henoxone purpura, that's HSP. We must not miss the diagnosis in ladies who are repeatedly giving miscarriages and giving history of bleeding, giving history of recurrent abortions and thrombotic episodes at a very early age. Maybe a lady getting married at the age of 22 gives 3 or 4 history of miscarriages and a stroke and history of preeclampsia. We must be very cautious and understand that there is a chance of an antiphospholipid antibody or lupus anticoagulant syndrome. Sign of intravascular hemolysis, as we have said, that hemolytic anemia, and this is associated with thrombocytopenia and alternation of renal function. We must see that these patients are often accompanied by alternation in their consciousness. The patient is confused. The patient may be suffering from a TTP. Low RBC, low WBC, and low reticulocytes plus low bleeding. These are very important combination that when there is anemia, when there is leukopenia, and when there is thrombocytopenia, this mandates a routine marrow biopsy to rule out aplastic anemia. Now let us check out the hypercoagulable states. Most important being the deep vein thrombosis. We get this almost every 2 or 3 days, every alternate days. Strong family history is very important. Mean age of presentation is more than 30 years. Patients who are obese, on oral contraceptive pills, collagen vascular disorders, and diabetes, and reduced mobility are at high risk. We know that in our modern urbanized life, people are obese, taking oral contraceptive pills, suffering from diabetes, and paying hours together in front of mobile phones or computers. They are at high risk, of course. Most common site is a deep leg vein. Calf tenderness is accompanied by a positive Homan sign. Homan sign is something like we take out the feet and put it a forceful dorsiflexion. It creates a discomfort behind the knees. The diagnosis can be done on Doppler ultrasound. So while we have gone through the very common disorders of coagulation, we will directly go to the diagnosis of certain WBC disorders, which are again must not be missed. Usually in clinical practice, isolated rise of WBCs are mostly due to various infections, and we often do not get worried about them. However, they may rise or fall due to a large number of causes, like those from hepatitis, autoimmune disorders, and most importantly, malignancies, and its treatment also. A strong clinical suspicion must be there for early diagnosis of these conditions. Now let us see how we will approach with a case of leukopenia. Leukopenia are often incidental findings. Because of often being the earliest sign, it needs thorough protocol-wise workup for determining the cause. Initially, a thorough clinical examination is needed. That is, if we get a case of leukopenia, what are we supposed to do? What are we supposed to see? We are holding a report where the RBC is suppose 2000 per cubic millimeter. What are the things we are supposed to see? We must check out for adenopathy. We must palpate the lymph nodes. We must look out for splenomegaly. We must look out for if there is an ecchymosis or purpura or petechial spots, and we must do routine blood examinations. Primary workup, look out for localization of infection. And of course, there is a non-localized fever. There is no localization of infection, but the patient is coming with fever. Different types of leukopenia, differential leukopenia gives us an insight to the diagnosis of the cause. So at this stage, we are holding a report of leukopenia. It is important to know what might be causing an isolated leukopenia. So isolated neutropenia is most important finding in cases in persons who are taking chemotherapy for any cancer. That can be very evident from the history. Hepatitis. All neutropenia requires a hepatitis B, hepatitis A, and hepatitis C is hepatitis C serology. Tuberculosis and tuberculosis and sepsis. Vitamin B12, mostly copper estimation. Autoimmune disorders can also present with isolated neutropenia. We must say that patients who are suffering from long-standing may show long-standing from rheumatoid arthritis with small spleen, just like a small spleen we have seen in cases of ACA. can see in cases of Fell's syndrome. Almost exclusively, neutropenia is associated with pancytopenia. It's a very, very important clinical clue we must bear in mind. It may be due to causes involving the bone marrow, like a cause where the bone marrow is unable to produce the neutrophils, that is the aplastic anemia and myelodysplastic syndrome. Myelofibrosis, this can only be diagnosed with the bone marrow biopsy. Rare causes include Wegener's granulomatosis, any immune vasculitis with anti-neutrophilic antibody positivity. So, a patient coming to us with leukopenia before referral or before going into the further intervention to the patient, we must do a few follow-up investigations like measurement of ANCA, measurement of hepatitis serology, viral serology, measurement of collagen vascular disorder serology. Some patients may have congenital neutropenia that usually is not life-threatening, but these patients show congenital low numbers of neutrophils in their blood, that's known as Postman syndrome. Now we are going to another category of differential leukopenia, that's eosinopenia and monocytopenia. Eosinopenia occurs most commonly with steroids. Nowadays in urban areas of our practice, we are seeing people coming to us with lots and lots of patients taking steroids for their asthma, for their allergic bronchitis, for their allergic manifestations on skin. Their patients are taking steroids. Many of them are developing a chance of developing Cushing syndromes. These patients are, of course, almost always eosinopenic. Monocytopenia. This monocytopenia is almost always associated with neutropenia. And just as I've said in my previous slide, that whereas neutropenia almost always gets combined with monocytopenia, similarly, monocytopenia and neutropenia almost always combines with pancytopenia, where a diagnosis of aplastic anemia, at least a clinical suspicion of a life-threatening aplastic anemia, can be done in clinics. Now, another important thing, that's a lymphocytopenia. Viral infections, cancer, and other diseases that is damaging the bone marrow, aplastic anemia and Hodgkin's lymphoma. Autoimmunity, again, the cancer treatments, as we have said, severe physical exertion, endogenous steroid-induced malnutrition might lead to an isolated lymphocytopenia, that's myelosuppression, splenic destruction or hypersplenism, viral hepatitis, brucellosis, cytomegaloviral infections, alcohol abuse and portal hypertension, and cirrhosis of various causes, including post-hepatic cirrhosis. Now, let us approach to a case of leukocytosis. We are holding a blood report, where the leukocytes count is 20,000. So the first thing that will come to our mind is an infection or fever, or clinical. We'll try to find out whether there is a fever. So there is a clinical findings we must take help from the clinical findings. So we can do culture of different body fluids. We can try to find out the source of infection. Most important diagnosis of infection, but we can see that the patient is giving a clinical picture of sepsis. The patient is having a clinical picture of sepsis, high respiratory rate, high pulse rate, high temperature. But to confirm the diagnosis of sepsis, we must confirm the diagnosis of sepsis, or the high fever may be due to other causes. High fever may be due to an acute blast crisis, or it may be from sepsis. We can do simply with a tip of finger test with measurement of procalcitonin, we can understand that whether the patient is having sepsis or not. Procalcitonin is a good indicator of an ongoing sepsis in human body. Chronic inflammation like collagen vascular disorders, etc., we can do our routine follow-ups for that. Reactive causes like exercises, panic attacks, recurrent panic attacks leads to leukocytosis, smoking, post-surgical stress, and post-seizures. So how will you understand these causes? This group can be understood from the history of the patient. Now, marrow stimulation, the recovery phase of bone marrow transplant, hemolytic anemia, etc. Loss of splenic destruction. We must remember that hemolytic anemia can be confirmed with measurements of LDH and high reticulocytes. Flow cytometry is done in some selected labs of Kolkata, where we can do it to understand various type of lymphocytopenia causes, especially from the bone marrow, like that of immune thrombocytopenia or CLL we can do. Now let us directly go into the lymphoid cell line disorders of acute leukemia. Finding blast cell are pathognomic for leukemia. Leukemia usually presents with signs of pancytopenia, just like that of aplastic anemia. So anemia, normocytic, normochromic mostly. Poorly functioning WBCs make the patient prone to different infections and hemorrhages, like that of thrombocytopenia we have discussed previously. Most common presenting symptom for which the patient seeks help. A leukemia patient goes to our clinic, goes to any clinic of any primary care physician to seek help, that is from continued fever. Acute lymphoblastic leukemia is the most common leukemia of childhood. AML is most common leukemia in adulthood. We must remember that AML transmission from chronic form is indicated by a circulating rise of peripheral blast cells more than 20%. Certain subtypes like M2, M3, and M5 of AML presents with rarer presentations of chloromas, DIC, and gum hypertrophy respectively. So let us look, how do this patient look like? So here we can see these are the pictures taken from American School of Haematology website, ASH website. Here we can see in the left picture, we can see there is an orbital chloroma of acute myeloid serous leukemia and gum hypertrophy of AML. This gum hypertrophy, whereas the chloroma is completely easy to look and know, the gum hypertrophy has to be differentiated from other much less dangerous causes, like that of patients taking anti-epileptic drugs. That can be very evident from the history of the patient. Now, it is also important to have do the basic clinical try to elicit the basic clinical findings. Acute lymphoblastic leukemia and chronic myelocytic leukemia often presents with joint pains, fever, and severe anemia. It is often misdiagnosed as rheumatoid arthritis in childhood. Sternal tenderness, as we have tried to show in the picture, that putting a thumb on the sternum, manogram sternum, putting some pressure elicits significant amount of tenderness, is a good clinical clue to diagnosis of ALL in childhood. So if still doubt exists, we can try to differentiate with measurement of anti-cyclinated polypeptide antibody, that is anti-CCP antibody for rheumatoid arthritis. We are seeing a patient of suffering from acute leukemia being treated in specialty cancer care, but the patient, as their primary care physician, we must have a basic idea of how to keep the patient prognosis known, how to monitor the patient. So here we can see that the patient, it can be often very useful for us to understand how the prognosis can be assessed in clinically. So the age group is very important. The good prognosis is 3 to 7 years of kids. The sex in females, they are way more good, showing good prognosis. Important point is the measurement of testis. If we can do an ultrasound of the testis, we can find out that if the testes are not significantly enlarged, we can say that it's a good prognosis in acute leukemia, mostly acute lymphoblastic leukemia. And bad prognosis is present with presence of testicular enlargement. Hepatosplenomegaly clinically is a very, very important point to know the prognosis. A large hepatospleen, liver and spleen, and nodes means bad prognosis, whereas the reverse indicates a good prognosis. And the AML can be single-handedly monitored with LDH along with other components of monitoring. That's LDH is low, is good prognosis, whereas high is termed with worse prognosis. There may be many other prognostic markers which are done by specialty cares. Immunohistochemistry profile, nowadays, it's very common. Every cancer patient, every patient of hematological malignancies will be subjected to immunohistochemistry studies. PROD, FAB, cytogenic markers, and immunophenotypes are determined by specialty oncology centers. Now let's go into the chronic leukemia. B cell is the most common and usually found in adults over 60 years of age, and they are often asymptomatic. High WBC count, lymphocytosis is often only finding. However, hepatosplenomegaly and generalized lymphadenopathy is same. They do not transform into an acute leukemia, often less life-threatening. This is a very important that chronic lymphocytic leukemia are comparatively a malignancy of old age. They do not usually transmit themselves to acute leukemia, and the patient won't give us time before the patient leaves the family. It won't so happen soon. Course and prognosis of CLL depends on clinical staging. Some cases may transform into B-cell lymphoma, also known as Richter syndrome. So this is a very interesting point of chronic leukemia, that the patient, chronic myeloid leukemia, that's the asymptomatic patient. This CML is often can be asymptomatic. The patient may find an incidental finding of upper left quadrant discomfort. So the massive splenomegaly is often presenting symptom. Whereas in cell leukemia, whereas in sickle cell anemia, we have seen the spleen is getting smaller. But just like in cases of hemolytic anemia, in CML, we are also hemolytic anemia from extravascular hemolytic causes. In CML also, we are getting a large spleen. So in the picture, we can see this big spleen of a patient of CML. The condition often ends in blast crisis of acute transmission. Usual presentation of this condition is due to WBC or platelet dysfunction. This patient may present with bleeding episode or thrombotic episodes and infections. Philadelphia chromosome positivity is common in adult CML, is associated with good prognosis, but when it is associated with acute leukemia, it is an indication of worse prognosis. Yes, because CML is comparatively common and forms a truly worrying differential diagnosis of splenomegaly, we must understand that what are the things which can help us to refer the patient or to do basic diagnostic investigations. We must remember that lymph node enlargement and hepatomegaly usually do not occur. The splenomegaly is an isolated splenomegaly in cases of CML. Massive splenomegaly, infections, and bleeding and thrombosis, they form the clinical triad of CML. Let us go into the final part of lymphomatous disorders that we all know, that Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is the mean age of presentation year is 39, whereas the NHL has a mean age of presentation 55 years. Asian usually affects the upper trunk glands, mostly cervical. NHL can present with swelling of any group of lymph nodes. Just as I mentioned, that it must be remembered, only based on clinical findings, it is impossible to differentiate between Hodgkin's and non-Hodgkin's. So every suspected cases must be subjected to histopathology and staging. Points to remember that prognosis of Hodgkin's lymphoma is best done by staging. The staging comprises of a single group on extranodal involvement, diaphragmatic polarity, which side of the diaphragm or how many areas in and around the diaphragm the involvement is there, and involvement of extra lymphatic organ. As the primary physician, as a primary care physician, we must understand, we must know this, that presence of systemic symptom in an HL or non-NHL patient, like those of long-standing fever, weight loss, this indicates an worsening prognosis, which we can say even without seeing the report of a biopsy. Presence of Reed-Steinberg cells, lacunar cells, popcorn cells, we have seen, we tried to show here the Reed-Steinberg cells as if the nuclei are mirrored. So points to remember again in Hodgkin's lymphoma. Histologically, nodular sclerosing is the most common. Lymphocyte predominant variant, which is diagnosed again histologically, with prominent popcorn cells, they have the best prognosis. We can assure the patient. Lymphocyte depleted and stage 4 variant has worse prognosis. We can, from the right side image, we can see what does a stage 4 lymphoma means. There is an extranodal, extra lymphatic site involvement. There is multiple involvement. There is involvement both sides of the diaphragm, up and right. We can see. Some lymphoma may present with paraneoplastic symptoms of cerebellar degeneration. Suspicion must be high to detect diseases in this early stage. Once the histopathological diagnosis of non-Hodgkin's lymphoma is confirmed, we must keep the following things in mind. Intra-ICH immunohistochemistry and histology is done in oncology cares. As primary care physician, our job is to refer to proper areas, and we must be knowledgeable about the classification of NHL. Patients with report of histology showing follicular and small lymphatic variant are usually having a low-grade neoplasm. Patients with intermediate grade neoplasms are diffuse, small or large cells, but patients with high-grade NHL are large cell immunoblastic or large cell lymphoblastic non-Hodgkin's lymphoma variants. So these are rare cases of lymphomatous malignancies, lymphocytic, but we must keep in mind because they also present with fragmentary but important clinical syndrome, clinical picture. That's the lymphoblastic lymphoma are highly aggressive neoplasms, and they usually present with a silent mass in mediastinum. Patient may present with later phases of life. These are highly aggressive neoplasm. The patient often gets diagnosed when there is a dissemination of malignancy, and they present with a large mass and can be done in HRCT thorax. Burkitt's lymphoma is common in African population, and it's usually present in children as in form of jaw tumor. That you can see in the picture in right side that there is a jaw tumor in Burkitt's lymphoma. Hairy cell leukemia is a distinct form of B cell, can be done and must be dealt with care and treated with the CML. Mycosis fungoid, that is cutaneous lymphoma, it's a diagnostic challenge for skin clinics, and it's a type of cancer involving the T cells and showing a skin manifestations known as mycosis fungoids, as you can see in the picture. Now, the plasma cell malignancy, that's multiple myeloma. Multiple myeloma, we all know that it's a malignancy of the plasma cells. The plasma cell line is not working properly, producing abnormal immunoglobulins, incomplete immunoglobulins. Increased number of abnormal immunoglobulins may result in 3 events. These immunoglobulins in the form of Baines-Jones protein, light chain protein, they get precipitated in the kidney, resulting in kidney failure. So kidney failure is a prime cause of death in multiple myeloma. Ineffective defense, as because the antibodies, the immunoglobulins are not proper, so they might lead to a faulty defense mechanism. So the patient will, again, just like WBC disorders, will present with recurrent intractable infections. Interference with clotting factors and amyloid damage to endothelium, bleeding tendency may occur. Hyperviscosity may occur, like headache, visual disturbance, vertigo, and tinnitus. So here I have tried to show that 3 components. If we can demonstrate 3 components in a suspected patient, we can understand the diagnosis of multiple myeloma. That you can see in the left side, upper left picture of a bone destruction in lytic bone lesions of a skull patient, as if the bone is being lysed and decayed in spots. Now, Baines-Jones proteinuria, it can be diagnosed in lab setting with the urine of the suspected patient. And once these 2 are positive, as the general practitioners, we at least must order for a serum electrophoresis to demonstrate the M protein spike. That's the myeloma protein spike. At the end of the conference, it's not the part of the seminar, but I tried to evaluate, try to enlighten some of the knowledge of homeopathy in homeopathic, as in the form of homeopathic approach to blood disorders. So we must remember that all these blood disorders can be largely classified into 3 parts. They are autoimmunity, there is proliferation and destructions and lysis, as in the form of autoimmune destruction in case of idiopathic thrombocytopenic purpura. So autoimmune hemolytic anemia. We can see proliferation in any cases of thrombotic disorders where the platelets are getting thrombosed, where the platelets are getting aggregated, where the platelets are attaching itself with the endothelium and forming a clot. It is a psychotic, it can be termed in oversimplified way as a psychotic manifestation of the sickness. As in the form of malignancies, as in the form of hemolysis, as in the form of leukopenia, we can find out a significant amount of syphilitic component in patients. However, it seems that these patients are mostly trimiasmatic with prominence of different miasmatic planes at different parts of the sickness. So in a nutshell, some group of homeopathic drugs, some approach to homeopathic drugs, which might help us in conditions like this. As in previous slides, categorization of hematological disorders on basis of their fundamental abnormality, because hematological disorders are every day getting increased. As our knowledge of cytochemistry, as our knowledge of immunity is getting increased, Might be we are going into a bigger field of every disorders. But sticking to the fundamental philosophy of homeopathic medicine, we can find out this all these conditions can be grouped and classified to three simple categorization of miasmatic study. While the drugs that shows pathological suppression of bone marrow, like anilinum, benzene, etc., in homeopathic potency, can help us to combat ranges from erythroid bone marrow disorders to leukemia and can open a wide range of research with homeopathic potencies. Drugs like allium sativum, hibiscus, euphorbia, ginseng, granatum, etc., shows in vivo marrow stimulation, hence useful in aplastic anemia and plasma cell disorders. What I personally think is that drugs most commonly derived from the group of ophidia, like shows immune control of platelet disorders, namely lacases, namely Crotellus horritus, namely Niger and I specifically recommend toxicophyes and lacases in blastocysts. Drugs from radioactive sources like uranium nitricum and radium bromide show similar manner involvement. They can also be helped to combat the side effects of a patient suffering from the chemotherapy of leukemia. So at the end of the conclusion, we can say that with progression of humanity, medicine is bound to evolve, but the philosophy of treatment must remain the same. Early diagnosis, early treatment, and timely diagnosis is the key to save us all. The scientists are always trying to unlock the doors of biological mysteries in cells, bone marrow, cell walls, while as the clinician, we must be very vigilant about the sickness, about the possible outcomes. And homeopathy as a modern, individualized mode of therapeutics that curates patient-based therapy is now believed to be the medicine of future. As the future torchbearers of individualized, ultra-diluted medicine, we must be very conversant with recent developments in research and incorporate the advancement in our clinics, bedsides, so our very existence can proudly utter the mighty words of Saint Mother Teresa, that hands which help are holier than the lips that pray. So I thank you all for listening to the speech.
Thank you, Dr. Tirthankar, for your wonderful presentation. It is a huge topic, and as Master says, means every physician must know what is to be cured in disease, and knowledge of the disease is very important. Okay, so what is the knowledge of disease? It is a hematological disorder. It's a very huge topic, starting from if we consider the blood in two groups, lymphoid series and myeloid series. So there is platelets also, and various other cells, erythrocytes and megaloblast series. And on the other hand, lymphoid series, it also contains the various like natural killer cells and lymphocytes. So in one in within 1 hour, it is very tough to complete all these things, but Tirthankar has nicely presented his topic, and he has started with various uh, means diagnostic approach of anemia, microcytic, macrocytic, and normocytic. And if a patient comes with macrocytic, it may be due to means folate deficiency or B12 deficiency. But if we if the patient also presents with peripheral neuropathy, then we can clearly understand that it is a case of vitamin B12 deficiency. So uh, that is a point we have to keep in mind. And and from the peripheral blood examination, also we get some important clues, like some abnormal blood cells, like target cells we get in thalassemia, like we can get the bite cells in G6PD deficiency, we can get sickle cell in cells in sickle cell anemia. We can get the teardrop RBC in myelofibrosis. So there are various abnormal cells that is found in sparse cell, burst cell. So various kinds of abnormal cells is present in peripheral smear that gives us a clue regarding the diagnosis. And also some inclusion bodies, like if a patient presents with Howell jolly body, then we may think that patient may be suffering from thalassemia or basophilic stabling. So uh, that is also can be present in thalassemia or late poisoning. So various clues we can get from peripheral smears. And regarding blood examination also, we have to know the uh, normal range. Okay, so uh, every normal range you have to know, and the cutoff points means if most of the laboratory gives the cutoff range, but if there is not available, then we have to diagnose the patient. Okay, then we should not search the that uh, electronic medias. Okay, so we have to be very much informed about all these things. He has also nicely discussed about the hemolytic anemia and various types of various common causes of hemolytic anemias and its diagnostic approach. And he has told about the red cell distribution with that is very important for thalassemia and also sickle cell anemia. And also he has touched about the coagulation disorders, various coagulation disorders, and its classification and diagnostic approach. And lastly, he has mentioned WBC disorders, starting from leukemia and um, leukocytosis. Okay, so uh, and there also he mentioned ALL, AML, and CML, CLL. So all these diagnostic approach we have to be kept in mind. So whenever a patient comes with blood report or some symptoms, we can suggest them for those investigation for diagnosis. Okay, so it is a very wonderful presentation. Thank you again. So if there is any question, then that can be asked to both the speakers.
Thank you, Professor Samir Manna. I'll request Dr. Kalyani, sir, and I'll request first of all Dr. Pralay Sharma to give his views and appeal. Dr. Pralay,
Yeah,
appeal for
I
all the
can.
alumni.
Yeah, I think that I'm audible. And it's a wonderful stay for
Yes, yes.
uh, 2 hours, 15 minutes out here in this platform today. We have listened to Dr. Rajiv and Dr. Tirthankar's wonderful uh, saying and a beautiful pronunciation, as well as a good voice, in fact. And the information were been very excellent for in connection with the education. And once again, I would like to thank both of them. And today's moderator has been very kind enough to be here in this platform, and his moderation was unique for all of us. And as we see that day by day, our viewer in this platform is increasing, and with all interest, they are viewing this webinar. And I believe that our association, our alumni association, being a very stronger platform in the country, as you all know that uh, 23rd batch of postgraduate trainee are joining our institution on 1st of March of this year. And regarding the BHMS, we have 28 batch of BHMS students have joined this institution. So we have including BHMS and MD and DPNH ex-students. Right now we have around 2,600 600 alumni in our association. So I believe that our association is very strong right now, and this association can take part in the making of the policy of the education. And as you all know that newly formed National Commission for Homeopathy are in action and in with a very positive approach. So I believe that like that of a webinar committee, like that of our CME committee, we can make one committee who can govern, we can control the education policy as well as the policy for the patient care, and give a good positive input to commission. We can exactly can give a good the phone coming uh, uh, good positive input in the in the commission, as commission National Commission for Homeopathy is functioning very well right now. So it should be our responsibility and duty, considering that we do have sufficient number of patients, sufficient number of the members of alumni association. Uh, in the same time, what I would like to say is that we will form a very active committee to control, to govern this educational policy and the policy of patient care, in fact. So that is my honest request to the to our secretary as well as the president, that let us make one committee, taking the members from across the country. We can make it a committee, and as well as we can function for the betterment of the homeopathy system of medicine. Nothing to add, but uh, what I always say, and this is a repetition of the appeal once again. Out of this 2,600 around alumnus, those who have subscribed, those who are the regular member of our association, we do not have we are thankful to them, but there are many who haven't become a member officially by a subscription of 100 rupees per year. I'll request, this is my honest request to all of them, to be member of the alumni association, to be a bona fide member of this alumni association by by subscribing this 100 rupees per year. And at the same time, I would like to say that we have a benevolent fund. Whenever it is needed for the alumnus, in any circumstances, we are there. Our fund is ready to get dispersed, ready to move to the person who needs real help. Our secretary, our president, and our committee is very active into it. We always keep information about each and every person, each and every alumnus out here uh, in this platform. And I believe that this benevolent fund should be enriched well enough, so that we can, in future, if needed, we can go for the help of our alumnus too. So this was the two part of my discussion today. Right now, one is to form a committee for to control the educational policy and the policy for the patient care. The committee will give some uh, kind of uh, kind of information, some kind of suggestion to the National Commission of Homeopathy, as we consider our association is the strongest and the biggest association in our country right now. This can be done. Second one is a subscription to all of the alumnus. It was a request. And next one was to contribute any amount of donation in the benevolent fund. That's all from my part. Thank you so much. Uh, thank you, everyone. Nice to hear all of you. Thank you so much.
Thank you, Pralay. Thank you for your so thoughtful views, and we all have to ponder on it. It's a positive way to go move ahead, and we have few very exciting announcements because of tireless efforts from all the team members of this CME, our YouTube channel had been on the first stage platform, and we are now active on with the super chat. So at the end of the session, Orko, before closing, will be discussing or he will be giving his message. Now, so far I was checking through. Uh, there was no such question overall, but certain praises, and we have uh, so far 180 live viewers who had been watching live YouTube. To close and to give his views for tonight's session, over to you, our respected Dr. Kalyani, sir.
Thank you, Bidyut. Many thanks to all the participants on screen and out of screen. Special thanks to our beloved Dr. Prahlad Sharma for giving a beautiful advice and for his information and your information also. Professor Choturbhuj Nayak, ex-director of C.C.R.H, has recently contacted me and Dr. Bidyut Mukherjee. He is arranging setting up one system of education and research compiling to present before the ministry. So all of us who are in touch with education and research should try to help him, should be ready to help him in any need. Number two, definitely we can make an smart committee. Your suggestion is very much needed for brilliant members to suggest our homeopathy commission for better education and researches. I should pay special thanks to our inaugurator, Dr. Manjeet Singh, for beautifully inaugurating the program. Brilliant moderation by Professor Dr. Somir Manna. Excellent presentation by two of our brilliant speakers, Professor Rajiv Sarkar and Dr. Tirthankar Banerjee. What I was feeling, I think many of you might have this feeling that we were for 2 hours in an emeritus postgraduate class, one on recent pandemic, other on hematology. Anyway, this, especially the presentation of Tirthankar Banerjee, remind me one history. You might be knowing, many of you might be knowing Professor Debabrata Pal, D. Pal of medicine. On the first day when he came in the dependence class in Amma Street with an umbrella in his hand and very simple dress, looks like an uncle, not like professor or doctor, with a half shirt and ordinary pant. And he came in the class and he told, see, I will teach you only two subjects. One is anemia, other is diabetes. This year I will teach you only anemia. And he gave a brief description on blood cells and he left classroom. We started rumoring that what type of man he is. Only anemia in 1 year. We had almost postgraduate dependent students who has already completed medicine. But after completion of the year, we found that really anemia, especially blood cell dyscrasia, is such a disease which can cover about 50 to 60% of diseases. It means huge spectrum of diseases can be covered if we start with anemia. So just imagine how much important to concentrate on hematological study and hematological investigation is. Next, I will tell you one more thing, that all of us, we must agree that there is a difference between basically homeopaths and converted homeopaths. All of you find, starting from our master Hahnemann till date, that always converted homeopaths, those who are modern medicine or allopathic system of medicine, converted to homeopaths, they become more successful than us. Definitely the reason is difference of knowledge. The people who are converted, becoming converted homeopaths, they are definitely scientific minded and studied in depth all the subjects, starting from anatomy, physiology, pathology, medicine, every subject in details. Then only they realize that homeopathic system is better than the modern system of medicine and they convert it. That should be our target too. We should not ignore, especially I am telling who are students on or who are teaching students. Please try to emphasize please try to inspire students that not to neglect the basic subject, that is anatomy, physiology, pathology, medicine, etc. Because only those knowledge of those medicines, anatomy, physiology, and ultimately the diagnosis will make a successful homeopathic doctors. You see, the benefits of diagnosis by investigation, minimum is hematological. I will tell you one by one. You must agree that first benefit is knowing in depth of the paraclinical subject. First benefit is confidence. The more you learn, more you get the confidence. Knowledge is power, ignorance is weakness. And the more you learn, the more you will realize how little you know. If we do not learn, we will feel that we have learned many things, we know many things. But once you start learning, as we have seen today's seminar, 2 seminars, pandemic, COVID-19 and hematology, how little we know, how much you have to gather knowledges. So please be inspired to go in depth of every subject as much as possible. The first benefit is power, strength, mental strength. Second benefit is diagnosis will give us prognosis, management, selection of potency, and repetition, posological measurement. If the case is not properly diagnosed, we cannot come to a perfect or confirmed prescription, because homeopathy deals with only uncommon peculiar symptoms. If we do not know in depth of the common things, symptom signs of the diagnosis, symptom signs, common symptoms and signs of the disease, how can we come to the conclusion of uncommon peculiar things? That is why to become a good homeopath, successful prescriber, in-depth knowledge for diagnosis by investigation is essential. Number 2 is, once you advise a patient for investigation, definitely you have experience, definitely you might have experienced that patient gets confidence. What confidence? Number 1 is doctor is knowledgeable doctor, not an ordinary doctor, simply giving homeopathic medicines and leaving the patients. He is searching, trying to find out what else is there, how far it is there. So that is the benefit of practitioners before the patient, to improve the confidence of the patient in the practice and hospital. Next is documentation. Once we advise for investigations and keep the documentations of improvement or cure, it gives us further confidence regarding cure of such type of diseases. So documentation before, during and after treatment is very, very important for self-confidence. Lastly, I will tell you, as a research person, unless we start documenting, all of us or most of us, unless we are confident regarding the cure of homeopathy medicine certified by the experts of the modern medicine, that means pathologists, serologists, sonologists, radiologists, we cannot proceed for further research and develop homeopathic system of medicine. Finally, one more critical thing, all of you must be careful regarding this thing, that is, unless you suggest any investigation, unless you confirm your diagnosis, you might be called by the court for negligence of responsibilities, and you may be charged of penalties. So nowadays, law has become very tough. Medical practitioners should be clear of their sincerity. You have tried your level best to cure the patient by investigating inner changes of the body. So for these purposes, please do not neglect in any way any sort of investigation, even if it is necessary. If you find a little indication, slight indication, there also you ask for investigation. Nowadays, if patients are not affordable, ask them to go to the hospital. There are other minimum cost laboratories also. Advise the patient to investigate, get the case confirmed, and select the confirmed medicine. Selection of medicine by confirmation is definitely still lacking in our system, which can only be achieved by this system. That means gathering knowledges, investigation, documentations. Thank you very much. Again, I am requesting to all of you, This type of brilliant seminars are really very much encouraging, and this is our improvement. I have told you that previous Union Minister advised us to provide help to the National Institute of Homeopathy. We are trying through the CME to increase the knowledges, to see the documentation of cases. So please help from all sides. Inform to your friends, brilliant teachers, researchers, where a practitioner has to come forward to present their experiences before all of us, to be encouraged and achieve confidence all around. Thank you very much and good night to all of you. Thank you.
Thank you, sir. And by this, we are returning back to our backstage editor, Orko.
Thank you all. Thanks for watching. I hope you have liked this video. And as said earlier, currently we have turned on the super chat button. If you want to provide while on live stream, if you like to provide any sort of amount, if you want to just provide with the super chat button, you just get it while you type the message. You will get beside a dollar sign. Just click on that. You will just chat with the super chat. So if you want to just donate something to the IT fund, then you can just click on the super chat button and send few amounts while on chat. And if it brings up, means the super chat will bring up the main names and the questions. In if the questions such a loss going on, then you can just question there too, and also give some thanks to anything else, just an appreciated amount on that super chat button. You can just click over there and just provide us with the super chat if possible. And so once again, thanks for watching. I hope you have enjoyed it. And due to some technical errors in with our IT department, currently the last two CMEs is certificate, means winner certificate, has not been issued, and this CME we didn't got any since due to technical snags. We didn't went through the lucky draw process, so that's why we didn't announce the winners for today's CME. So thank you all to them. Thanks to all to them, and congratulations to whosoever got the registration certificate on mail, because only those people gets who gets all the 6 questions right. They only gets the registration certificate. If you have gotten it, then congratulations to you. And with this technical snacks also, we today were unable to produce any auto e-generated certificate too. So sorry for that, sorry for this inconvenience, and I hope you have enjoyed this. And if you want to uh, know more about this CME thing, CME, this online CME, then we have tons of online CMEs done. This is 43rd, and we have from the starting one. So go check our channel, and we have lots of stuff to see. So just click on every video, click on the video you like, just check it out, share with others, share with your fellow homeopaths and fellow medicos. And that's it. Follow us on Instagram, join our Telegram channel to get updated as earlier as possible, and also subscribe to our channel. The red color button, if you're saying it's red, then click on it and then click on the bell icon and press all to get notified as early as possible, as soon as we just schedule the CME. So with this, it's me, Medico Orko Mukherjee, leaving. Have a nice good night.